Well, for a little bit more on this, we're now joined via Zoom by Professor Saiqa Mullick, who's the Director of Implementation Science at Wits, the Reproductive Health and HIV Institute. Thank you so much indeed for joining us, and welcome to the program.
Thank you very much for having me.
This sounds quite exciting, the idea that an injection could prevent people getting HIV.
Yes, absolutely. I mean, I think this is really good news for the field. And as you know, we have the daily oral pre-exposure prophylaxis, which is now available in many of our Department of Health primary healthcare clinics. But having an additional option means that we can now provide our communities with a choice of HIV prevention methods. So this is really good news.
All right, an additional choice, perhaps different delivery. Tell us a little bit about what's different with this one.
Okay, so what we have currently, as I mentioned, is the oral pill, and that requires someone who's at significant risk of HIV to take a pill every day. And we know that this can be difficult for people. They can forget, or other things can get in the way. And so this new technology is an injectable, which one would need to have every other month. So it's an 8-weekly injectable that is given intramuscularly, and would potentially get over some of these adherence barriers that people face.
Tell us a little bit about how it works and why it possibly will work.
So it is an like the oral pill, it is an antiretroviral, and it prevents HIV infection. So one has to be HIV negative to be eligible for the injection, and it prevents HIV from entering the body. So we also have another choice. Recently, SAPRA approved the dapivirine ring, which is an intravaginal ring, which releases the drug dapivirine, and is also an additional option. So we're waiting now for SAPRA to approve the injectable before we can make it available in this demonstration study.
All right, so I mean, to get to human trials, that means a lot has already been proved in the lab. Tell us a little bit about what's happened to get us to this point.
Yeah, so a lot has happened. So as you know, when products are developed, there's laboratory testing, and then it goes into a number of clinical trials. Initially very small trials, but then there are trials that establish the safety and efficacy of the drugs. And so these trials have already been conducted, and in fact, many South African researchers and communities have been involved in the development of both the dapivirine ring as well as the injectable. And so this study is what we call a demonstration study. So or an implementation science study. So the question is, what we know now that we have these effective and safe products, and our regulator will have approved them, but how do we deliver these in a way that is going to reach those people that need it most, in the most effective and cost-effective ways? And we need to learn what happens in real life, because as you know, in the clinical trial setting, these are very controlled setting and very specialized clinics in many ways. So this study, the demonstration studies, take those safe and effective products and figure out how do we deliver these in real world settings in a way that's going to be most equitable and effective.
All right, so how long will the study be for before you start to say, okay, we've got enough data, this is probably ready for the next phase?
Yeah, so we work very closely with the Department of Health. And this study is really what we're going to do is we're going to be offering a range of choices to people who are eligible. So we will offer oral PrEP, we'll offer the ring, and we'll offer an injectable. And what we want to see is what the uptake is, and try to understand who's going to choose which methods, how long they're going to use them for, will they switch? But at the same time, we're going to be learning about the supply side. What do we need to do in order to prepare our providers, our communities, and how are we going to support clients who are on these different methods? So it's really learning very practically in the real world what is required to scale this up. And we'll be answering questions that will be really helpful for the Department of Health in considering the best ways to scale up these interventions to other areas and other populations.
How do you find the people that are going to be part of this study? Because I would imagine there are some people perhaps who are at high risk. I'm thinking of sex workers maybe. But you also, I guess, need to get a good sample of just ordinary people, if I can use that word.
Absolutely. And in fact, yes. So we have a generalized epidemic. And so, you're absolutely right that we have a large proportion of our new infections really coming from, not from only from those key populations that you've just described. And so what we do typically is start very early working with communities and providing information about the study. In fact, the trial that we're going to do now, we've been working in those communities for some years now, and we're supporting oral PrEP delivery. And we are going to be working with communities, particularly with adolescent girls and young women, with community leaders, with other NGOs, to make to raise awareness about these new methods, but also to raise awareness about the study and where these products will be available in the community.
I suppose the challenge for science is you can find a solution, a drug, but it has to, in the end, be affordable. Is that something that comes down the line once you've figured out the drug itself?
So we know that long-acting cabotegravir is expensive at the moment, but we are aware of that. So, and currently there's a single manufacturer. So we understand that the manufacturer is now working with 3 other potential manufacturers to look at generic manufacture, but this is not going to happen overnight, and it may take some years. There is also a global coalition that's recently been put together, which includes the World Health Organization, which includes UNAIDS, and many of the large donors, as well as other technical partners, to really figure out what might the global demand look like. It's going to be very different in high-income countries, and it's going to be different in low and middle-income countries. And so they're going to be really putting their heads to predicting what that demand is, and looking at ways in which the price could be reduced.
How similar is it to this CAB-LA that we heard about last month, that Zimbabwe has just given approval for?
Yes, so that's exactly the same. It's the same drug. The injectable is CAB-LA, which is long-acting cabotegravir. So that's the drug, and we hope that it will become more affordable. I mean, part of the challenge around predicting the demand is that we have no real-world data around what that demand is going to look like. So projects like this are going to be really important to actually generate that real world data and to feed it into processes like those to actually be grounded in some real evidence.
All right, perhaps help us understand then, if Zimbabwe's Medicines Control Authority has approved its use, does that mean that somewhere in the world they've gone past the study stage that you're at and have already said this drug is good, use it, go for it? What are we then doing?
So, so our regulator, SAPRA, is also currently reviewing the CAB drug for approval for use in South Africa, and they need to be, they are going to be looking at safety for our population. That's what Zimbabwe's done, but Zimbabwe is also going to be doing demonstration study where Wits RHI is also involved in another multi-country initiative that will be doing a similar study in 5 countries, and Zimbabwe is one of them. So they're also at a similar stage. I think they're just a little bit ahead with the regulatory approval, but they'll also be looking at generating some real world evidence.
All right. I mean, this is all very exciting, but I'm left wondering, we've had HIV for decades and decades. Why do you think it's been slow to get to this point? And yet, when COVID-19 happened, we had a vaccine in 5 minutes, literally.
Yes. So, I think so the good news is that we've been, we have more tools in terms of prevention, and we've got better treatments as well. But we have been slow to roll out the tools that we have. It's taken 8 years to get to where we are with oral PrEP, and so we've got to do this much faster. And I think, with COVID, just the level of investment and the speed at which that happened was unprecedented. So they really, we need to really work with all the resources that we have and in a collaborative manner, because I think that's the only way we're going to really make significant progress.
All right, we've run out of time, but last question. How long do you think it will take before HIV will be something that we just inject at a certain age, like all the other drugs, and then it becomes a disease that disappears?
Yeah. Well, I think, there is a lot of work going on in terms of developing an HIV vaccine. It's had some ups and downs along the way, but I think we're still far off from an HIV vaccine. So for now, we're going to have to use the safe and effective tools that we have optimally. And hope that we have some good news in the future on a vaccine.
Well, we wish you the best, and we thank you for joining us tonight, and good luck with this study, because any step forward is an important one. Thank you for your time.
Thank you so much for having me.
Okay, that's Professor Saiqa Mullick, who's Director of Implementation Science at Wits Reproductive Health and HIV Institute. Yeah, we've got a new tool that's being tested, and an injection could, every 2 months, I believe, prevent people getting HIV. So something that we are investigating, and let's hope that it's something that will be available cheaply in the near future.